My name is Jemely Villegas, and I'm a nurse practitioner, just like Shannon said. And I've worked a majority of my career. I've been a nurse for about 28 years now, and 10 of those years I worked as a nurse practitioner. But most of my career, and I would say it's about 20 years of my career, was spent in oncology. 2 years ago, I switched it up and I started working in palliative care, which I do get because I feel that oncology is my passion, and this has been my opportunity to work with oncology patients. I would say my caseload, I would say 80% of my patients are oncology patients, and most of them come from Santa Maria, the Mission Hope there, and I do get a few from San Luis Obispo. And so I do get the opportunity to help with oncology patients, and I really enjoy it. It's almost my comfort level to be able to assist with oncology patients and be able to tap into my passion there. I will let Dr. Kadix, he is our medical director. He is very knowledgeable. I've learned a lot from him in the last 2 years. He's a wonderful speaker, and hopefully someday you'll get the chance to hear him speak. These are some slides that he has given to me, and I have to say he is my mentor through this new chapter in my career. So he's very, very compassionate and has a heart for palliative care. So I will give him the credit with these slides. And the next slide shows the acknowledgements, where these slides came from. And there are no disclosures, but he is the medical director of palliative and hospice. Next slide, please. And what palliative is about, and I will go over it in detail, but it's to prevent and relieve suffering and promote quality of life at every stage of life. Outline and objectives. What is palliative medicine? I will define and briefly describe the evolution of palliative medicine and just a little on why it's important. How is palliative medicine delivered and what services are available in the Central Coast? Understand the gaps in the treatment of serious illness and benefits of palliative care for patients, families, and the healthcare system. And I promise you, I will be reading the slides, but I will also have some input on what palliative medicine is about. I do consultations, and they give me the most complicated oncology patients. And that is the first question people ask is, well, what is the reason why you're here? And that is, to me, a multifaceted question. And first of all, we do get referrals from doctors. And I want to make sure that this topic isn't a scary topic. Oncology alone cancer is a scary word by itself. And we have no desire to add to the fear and the stress of what people are going through with cancer. So I want to be able to explain what palliative is and to make it less fearful and less of a scary issue. Next slide. So, new CMS definition of palliative care. And I had to look up what CMS is because I know these acronyms, but I don't know exactly what they stood for. So CMS is Centers for Medicare and Medicaid Services. It's a part of the Health and Human Services, And it's more related to government, more related to billing. And that's the reason why I became a nurse, so I wouldn't have to deal with billing and insurance. But that's what CMS and they have defined what palliative care is. Palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy, access to information, and choice. And to me, what that all means, because it's a lot of jargon, what that all means is knowledge, making an informed decision, and helping patients through their disease process. So next slide. And we can skip this part. Next slide. And skip that part. Sorry. So this is palliative care, patient and family centered, not disease centered. And that is so important. The oncologists, and this is with the practice that I was with, their job is to treat the disease, and oncologists have a very difficult time with coming up with treatment plans and going to the next level and doing multiple lines of treatment if that's what it takes, and they're wanting a cure. Our job is to come in and focus on the patient and how to control the symptoms. Now, the nurses at oncology offices, they are very good at doing that and recognizing what patients need. And they, as a nurse practitioner, they spend the most time with the patients in the infusion rooms, and sometimes they are able to get more information than a doctor can in the exam room. So our nurses, I value them a lot because they're our eyes and ears, and they're able to recognize and communicate to the doctors what is really at need here. And we have a palliative care team at Dignity. It's an interdisciplinary team, and we'll go into that, and I'll make sure you all know that it's not just a nurse coming into your home or a nurse practitioner coming into your home. It's a whole team that's involved with palliative care. So next slide. This is a great little snippet of, our Dr. Kadix has a great sense of humor, and he included this one clip, and I think it's pretty funny. Next slide. So these are care plan choices, the partial truth of Q versus Q, and that's quality versus quantity, and the risks and benefits involved. These are patient-centered decisions, and they entail of relieving the burden, trying to make it clear and easy, and trying to kind of take out the myths, misconceptions. Miracles are done every day, and we could either live like everything's a miracle or live like there are no miracles. So this is, and I believe that knowledge leads to empowerment, informed decision-making leads to power, and keeping in mind an individual's desire for treatment versus comfort care, because every individual going through cancer their experience will be different. And what I've told patients, because I did a lot of chemotherapy education in my life, and one of the things that I've always told patients is You could take the same disease, the same cancer, same stage, give them the same treatment, and individuals will react differently. Their side effects will be different. Their experiences. I truly believe that past experiences, a patient's personal history, it all comes into play when patients are faced with a chronic illness such as cancer. Next slide. So this woman, Dame Cicely Saunders, she was a nurse first, and then she saw the importance of palliative and hospice. And she's an English woman, and in order to make change, she felt like she back in that day, in those days, she felt that being a doctor would be able to have the authority to make changes in medicine, and that's exactly what she did. She went back to school and became an MD. And she started St. Christopher's Hospice in the 1960s. And other people, next slide, other people involved in modernizing palliative care and hospice, next slide, is Dr. Elizabeth Kubler-Ross in the United States in the late 1960s. U.S. government hospice demonstration project led to the Medicare hospice benefit in 1982. And out of that grew hospice care, palliative and hospice care. Next slide. Now, what makes palliative care scary is that a lot of people feel that hospice and palliative care are one and the same, and that they can be used synonymously. Not only patients feel that way, there's a lot of doctors who also feel that way. So a lot that Dr. Kadix does is he holds talks on the difference between palliative and hospice or end-of-life care. And he does that with our with residents, medical students, and even at the Dignity hospitals. So it's very important to know that there is a difference, and it's not one and the same. So non-hospice palliative care is appropriate at any point in a serious illness. It is provided at the same time as life-prolonging treatment, no prognostic requirement, no need to choose between treatment approaches. So I have a lot of patients that are on palliative care services who are currently receiving chemotherapy and or radiation. And the next thing to talk about, or another topic, is hospice. And it's a form of palliative care which provides care for those in the last weeks, few months of life. Patients must have a 2-physician certified prognosis of less than 6 months and give up insurance coverage for curative or life prolonging treatment in order to be eligible. And another misconception on hospice is that patients feel that once they get on hospice, that's it, that they only have sometimes days or weeks, and that's not always the truth. We have patients that have been on hospice for 12 months, 18 months, and sometimes even 24 months because of the good care they receive with the hospice nurses and our medical director. That's something that I just want everyone to know. The next slide for review. This is true or false. Palliative care is only appropriate when a patient has given up curative treatments. Palliative care focuses on the person at least as much as the disease. Hospice is synonymous with palliative care, and hospice patients must be a DNR. And next slide. So it's false. Palliative care is appropriate at any time during the curative treatments. And like I said, I do a lot of symptom management. We are considered a consultation service. So I go into the home and let's say something like nausea. So patients will go into the doctor's office and say, well, you know, everything's fine. And then sometimes they'll tell me that they only get nauseated the first 3 days after getting chemotherapy treatments. So then I go over their medications, I review their medications, and I find information like, well, I don't like taking those medications because it makes me sleepy. Okay, well, why don't we try taking it like right before you go to bed and see if that'll help. We look at alternative measures other than medications. We look at peppermint, we look at green tea, we look at ginger, all these different things that could help with that. And if they say, well, the medication that I have isn't working, then we'll make a phone call to whatever oncologist there is and say, well, would you be willing to try an alternative medication? And and most of the time, the doctors appreciate us calling and having other options, and most of the time they are agreeable to trying different meds. The second point is palliative care focuses on the person at least as much as the disease, and that's true because our main focus is wanting the patient to be comfortable and also acceptable of where their pain level is, and that's another symptom that we can help smooth out. And there has been so many times where I'll have a husband tell me, no, my pain is fine. And wife is sitting right next to him going, wait a minute, no, it's not. You didn't sleep last night. You weren't, your pain is not fine. And so then we kind of dive into that as, with the patient and the wife there. And we find out that things may in fact not be okay. The third point, the hospice is synonymous with palliative care. That's false. And hospice patients have to be a DNR. That is also false. Okay, next slide. So the focus of care, preventative, curative, and palliative. Preventative, the American Academy of Family Practice has guidelines: nutrition, exercise, chronic disease management, medical conditions, high blood pressure from becoming injury and illness, heart failure, stroke, and kidney failure. Curative, always the goal, but not always possible. Advanced chronic illness or organ disease, refractory cancer. Palliative, enhance and expedite curative measures, focus on person at least as much, usually more than disease. Help articulate and provide the best possible care. Provide insight, care, and relief, even if cure is not possible. Next slide. So that just says it all. We remember the person and not the disease. Next slide. So this is a palliative care referral. There's no easy way I can tell you this, so I'm sending you to someone who can. So palliative care, and that what I do is called community-based palliative care. So what we do is we do home visits, and I have found that patients are a lot more comfortable in their home. We're able to sit and talk on their couch or on their bed and discuss the things that they're going through, and sometimes it's physical and sometimes it's emotional and sometimes it's both. But we we do take the time to kind of break it down for patients. Sometimes talking out loud is helpful, and instead of just keeping it in their heads. Next slide. So clinical palliative care can go anywhere. Central Coast, these are the Central Coast services. So palliative care is in the hospital, and also what I do is community-based or home-based programs. And in the event that my patients who are open to palliative care at home, if they happen to go into the hospital, I call one of the palliative liaisons, and I just have them check on my patient, let them know that I'm following up on them even when they are in the hospital, and I'll be waiting for them when they come home. And sometimes that's a comfort of them being in the hospital and knowing that somebody is still monitoring them, evaluating them, and trying to cover all their needs while they're there. Next slide. So these are the things that we do go over when they are at home. When we receive the referral for the consultation, we know most of the time we get the last progress note, and we know the nature and the course of the illness, what options are available for treatment, and what does the person living with the illness want. That is like the number one goal, is asking the patient what he or she really is striving to have, and what are concerns for quality of life symptom control. We listen, we support, we educate, we advocate, we treat, and coordinate. Next slide. So our palliative care team is interdisciplinary. Dignity's palliative care team, this is not them. It's just a random picture that they pulled. But there's registered nurses on our team, social workers, our medical director, nurse practitioner. We don't have pharmacists, but we do have pharmacists with home health, spiritual care, and therapy is through our home health, physical therapy, occupational therapy, and speech therapy. And so this is what comprises the palliative care team at Dignity. And these are what's available. Our team is small. So my list of patients, I will be the only medical person that goes and follows them. So we don't have like multiple nurses that are following the same patient. We believe in continuity of care and just keeping everything tight knit. We have one social worker and one chaplain, and those are optional. We always ask our patients if they would like spiritual support or emotional support, any help with their insurance, any help with paperwork. Our social worker is really good at helping to navigate through all that. Next slide. So conventional cancer care, this is simplifying this slide is very simple, but it focuses the focus of care, and then that wide box is anti-cancer therapy, curative, life prolonging, or palliative in intent, and then that other piece is hospice care. So from diagnosis, and that's the time frame. So palliative care, we're not governed by any let's say government that says once goals are met, then we have to pull out. sometimes patients just feel comfortable with us calling them and checking in on them and seeing if there's anything that we need to figure out or help with. But we don't have like a set time where we have to pull out or discharge patients. If the patient feels comfortable and the nurse feels comfortable, then we can talk about discharge. If patients feel they don't need us any longer, then we can talk about discharge. And so there's no real set time frame that we have to pull out. But on that same note, if we do discharge patients, it's really easy for them to come back on if they wanted to. Next slide. This is just another slide that kind of breaks down the slide before that. Next one. Okay, so this one, preference. What do patients with serious illness want? And these are a couple, there are a couple of things, points with that. And one is pain and symptom control. The second point is avoid inappropriate prolongation of the dying process, achieve a sense of control, relieve burdens on family, and strengthen relationships with loved ones. Those are just some things that that we help do. And the other two, the next few slides, now these are from, this is old data, and so I'm not sure how relevant it is. So I'm just going to go through it just really quickly. So as you can tell, I didn't do well in statistics, and these numbers, honestly, they mean something to someone, but as a person who takes care of patients, I just don't focus on percentages and numbers as much. So we can just go through the rest of them. Let me see. Next slide. So palliative medicine equals quality of life. What we strive to do is relieve suffering, just enhance the communication with their physicians and their choices, use our interdisciplinary team throughout the continuum of care. So several studies have shown that it has improved patient family satisfaction and outcomes with palliative care. And the other slides are mostly case studies, and I'll go to the last slide for me, Remy. Sorry. Keep going. That's it. Oh, I'm sorry. Palliative care improves quality of life for our sickest and most vulnerable patients and families. Suffering is a universal human experience, and its relief a universal health professional obligation. So I'd like to end with that because I think that's a really important quote. And, you know, palliative care, I don't feel we need to sell it, because I just feel it's important, and everybody wants someone rallying around them, and but people need to understand what it is. And to me, it sounds great, and I love what I do, and I feel like it benefits a lot of people. I know it's a relationship that needs to be built on trust, and that is part of what gets us through the door. Is if they're trusting their oncology team, if they're trusting the knowledge of what palliative care can do, I feel we could do a lot of good in palliative care, and we're getting the word out, and hopefully more doctors will be able to feel comfortable sharing palliative care within our organization.